Muito obrigado. Tenho muito prazer para falar na frente de vocês essa manhã. E obrigado pela invitação. Vou falar em inglês porque é mais fácil para mim. I was going to say thank you to Dr. Botelho and Dr. Alves, but I'm only saying thank you to Dr. Botelho now because I was not ready for this attack. That picture was awful. So cervical radiculopathy, we just heard the extensive, the ACDF is still considered the standard of care for eliminating pain and unilateral symptoms. And the evidence is out of control now for adjacent segment degeneration. 70 papers published, and this was at least 10 years ago. I'm not going to dance around what has to do with that, whether or not it's instrumentation, but we know that there's linear Kaplan-Meier disintegration and the need for reoperation. We also see that increased mobility at those adjacent segments. The early results of minimally invasive PCF were very comparable to the reoperation rates, at least according to some of the first studies in multi-center studies. Multi-center studies also demonstrated that reoperation rate was significantly lower at adjacent segments. But one of the most important things, especially as what is becoming more important, is the costs. And this is a great study demonstrating the cost per quality of the operations of posterior cervical foraminotomy, and there's a significant, at least in America, cost savings when you remove implants. This is a paper that my group just published in JNS comparing long-term rates of ACDF and several hundred patients versus our posterior cervical foraminotomies, demonstrating a slightly less reoperation rate. And my clicker gets stuck here, sorry. We've extended this to a systematic review of the literature that will be published shortly in Spine, which elicited 14 high-level studies for looking at reoperation rates when compared to ACDF. And pretty diffusely across that, there's a 5% reoperation rate for patients eventually undergoing cervical fusion when all of those patients are pooled, and that's about a little over 1,000 patients. So the conclusions are it's safe, it preserves motion, it has shorter OR time, and significantly early return to work. The one thing that we have to remember is, and Oscar covered, kind of that this is very specific to patients, and I think the indications need to be expanded, but this is a case example of your perfect patient, 34 years old, unilateral symptoms, failed conservative management, has had some kind of improvement with injection, may or may not have spondylotic changes, but unilateral disc herniation. Again, the technique being talked about is keyhole foraminotomy, and I, again, prefer, there's a difference, I believe, with the tubular approach as opposed to any open or, well, maybe not endoscopically. But again, ideal patient, unilateral symptoms, no spondylosis, normal alignment. The procedure itself, at least in our hospital, setup time is between 45 minutes to an hour and a half. You have excellent working field with, again, if you can get good alignment and visualization. The tubes themselves do very, very minimal disruption to the soft tissues. Again, the tube itself has an excellent working area with fluoroscopy and microscope in line. And you, again, get excellent visualization and the amount of facet resection that you need, all within everyone knows our quarter. So my case example is what I would like to throw out to everyone here is this is a 48-year-old left-hand dominant spine surgeon. He has a persistent C8 radiculopathy and minimal neck pain. We can go over the options, but what would you choose when some of, this is a paper from Clinical Spine Surgery demonstrating that return to work, again, this is probably more important in the United States where we have to work like dogs and don't get time off. we need to get back to work quickly. So the pros, it's an easy approach, very minimal soft tissue disruption. There is no fusion, fast recovery, fast return to work. No adjacent segment concern that would be greater than any other technique. Again, the cons would be that there is recurrence, it is unilateral, and we cannot use it alone for instability. Thank you.